Good morning, everyone. I think we'll get started. Thanks so much for being here and on Zoom. It's really my distinct pleasure to be able to introduce a dear friend and colleague, Klaus Rabe, who's professor of pulmonary medicine at the University of Kiel and director of the Department of Pneumology in Grosshansdorf, Germany. So Dr. Rabe is really world-renowned in the area of airway disease, particularly COPD, but does a lot of work in asthma as well, and has had a lot of leadership roles over the years, including he's a fellow and past president of the European Respiratory Society, and he was president of the ERS when I was president of the ATS. So it was a pretty great liaison, because it was wonderful to have friends really across the pond, because the two leadership groups really interact quite a bit. And he currently serves as vice chairman of the German Center for Lung Research. He's past president of the German Chest Society and a member of the British Pharmacological Society, and of course the ATS. He served on a lot of committees, including the Global Initiative for Asthma, GINA, which is really our main guideline group where the guidelines are updated yearly, and also GOLD, Global Initiative for Chronic Obstructive Lung Disease. So you can imagine he serves on several boards of journals, including our favorite, American Journal of Respiratory and Critical Care Medicine, and it was past the editor of the European Respiratory Journal. He's received several distinctions, and one I wanted to tell you about was called the Balzan Award in 2019. For those of you who don't know about the Balzan Prize, it's an international award given annually to individuals who've made outstanding contributions in the fields of humanity, natural science, culture, and peace, recognizing exceptional achievements on a global level, so definitely outside of our sphere of medicine. And it's awarded by the International Balzan Prize Foundation. And so I thought that was a very an interesting award, with each prize winner receiving a sum of money, with half of it being designated to fund research projects involving young scientists. So I just thought it was a very unique prize. So he's, as you might imagine, Dr. Rabe has been active in various fields in respiratory medicine. Current scientific interests are related to large clinical trials in COPD and asthma, mechanisms of inflammation, and early determinants of lung health, which he will reflect on and discuss today. And he's been involved in many trials, both in COPD and asthma, and you've probably seen his name in the New England Journal and other places, other very prominent journals. So we're really excited that he was willing to cross the pond and visit us today. And I know he's got a lot of meetings with several of you in the audience, and so we're very excited to hear what he has to say. So thank you for being here.
Monica, thank you for your kind and exaggerating words. That's the nicest part of the day, I guess. But I'm looking forward to this whole day, or 1.5 together with some of you, and sort of, in talking to you directly. And I'm pleased and honored that I was asked to give you what he said, in the context of Grand Rounds, what I believe is one of the arguments to be a chest physician. I've spoken to one of you that sort of was deviating to cardiology, which is a big mistake, I think. So basically, here we are. I will talk to you a little bit about early origins of lung disease, of airways disease. And I tell you a little bit about this because it is part of what we do in the German Center, and I've taken a personal interest in this over the years, so I will try to allude a little bit on this. Now, these are my potential conflicts of interest they're manifold. I still believe I can give you a balanced account of what I think is important in this topic. I've read from the ATS annals or somewhere that this slide has been shown 0.6 seconds in ATS meetings. So I sort of deliberately chose to make this available to you that you can actually really take a note of what I'm doing or what I'm not doing. Now, what's on the menu? I'll tell you a little bit about the German Center, which is called DZL, which is Deutsches Zentrum für Lungenforschung. I say something about the embedding of it. And it is a center that is dedicated to translational science. And I will talk to you a little bit about this because part of this enthusiasm of our side is the fact that it is a translational science center. It is something that mingles basic scientists, geneticists with hardcore clinicians. And I believe that is where the fun is, where the fun part is. That's why I always took my fun part of it. This is what my DNA and joy in this profession is. And this is why I want to say something about what you do. I'll tell you a little bit what you should know about the fly. And I will leave it open there. And I'll tell you a little bit about the exposome, the prematurity, the epigenetics of obstructive lung disease. before I sort of, probably close a little bit about the windows of treatment opportunities, if you understand early origins of disease and you understand that probably development of interventions makes a principal mistake the way they're developed. And if you understand early origins, it opens the windows of opportunity where you are. So the German Center is, if you want, it's a political beast. It's been founded at some stage 15 years ago when people understood that drug development and translational science in Germany had a problem. They had these problems of different columns of organizations, universities and institutes and hospitals, and there was no intermediate layer. There was no sort of talking of these columns together. They were powerful, Max Planck and Helmholtz and you name it. And universities that had to do both. They had to do clinical excellence, and at 4 o'clock in the afternoon, they had to be scientifically excellent. Congratulations, that doesn't work. Then you have sort of the clinicians that actually sort of knew the clinical science, but they knew very little about basic science and they never talked to people. That's the reason why translational research centers were founded, and they were founded in all over Germany. They were founded for the low-hanging fruit disciplines, like obviously cardiovascular. Everybody wants cardiovascular, bless you. It's infectious diseases, it's cancer, and lo and behold, the lung. Because there were people that said, listen, given the epidemiology and given the importance of it, you need a lung center for that. And I think we've done pretty well. So what are we? We are 5 columns from the north to the south. Munich, Heidelberg, Marburg-Gießen in the middle, Hanover, and the north. I am the north, which is the Airway Research Center North, ARCN. And that's the place where I live and where I come from. We're just rebuilding this. It's 220 beds, pulmonary alone. It does everything from thoracic surgery, a big oncology unit, 1,200 lung operations a year, 600 new lung cancers a year, 15,000 people that are coming from a large range. So that is the biobank, if you want, of what we do in terms of translational science. And next to that, you see institutions that are around this, and also, for example, also a research center that does nothing but basic research, 2 universities, and that is the structure that I'm talking about when I talk about the science that we do in the north, just as a note of introduction. The center is centered around disease areas, which is very interesting. It's not centered around technology or disciplines. It is centered around disease areas because that's where it comes from. So you can go from asthma to lung cancer and regenerative medicine transplant. And you as a center, when you applied for this, choose which areas you would be excellent in, so-called. So we are asthma, we are COPD, we are lung cancer, based on what we know. And we are not cystic fibrosis because there are other people that are much better in it and they see much larger issues. For you, in terms of understanding what the beauty of this as well is here's the process. So I was in the Netherlands. I was at the University of Leiden, and I knew these people. And the chair, our now chair, we are 5 directors of it, called me and said, you have to come back. I said, why? He said, well, we founded the center. And you have to come back because we need people to run that, people that have enthusiasm for translation science. And we are now at teleconference 464. That's every Monday, 5 o'clock. I missed it yesterday, I was on the plane. Everybody has to be there to do that. So that's continuity of work. And that's what makes it very interesting. When we applied for this, we were 18 applicants, and these 18 applicants were reviewed by a board of 50% US, 50% is what you would call rest of the world. And that resulted into a selection of saying, we find under these 18 applicants, we find 5 centers that you see that are probably worthwhile. And then they gave us 100 days. They said within 100 days, you form 1 application from your 5 competing center grants in it. And that process was extremely rewarding because it made, it gave this sort of a homogeneity to this approach, which was very interesting, which is very nice. So next to disease areas, we have sort of work spanning groups. We have the biobanking, which is enormously important. So what we do is we select and collect all sorts of biomaterials that you have it from genetic materials. There's a broad consent nationwide now. Everybody that enters one of those centers signs that his cells, materials can be used for the purpose of the German Center for Lung Research. We have sort of associated scientific units that are around large clinical trials. And we have a microbiome-metagenome group. We have a single cell analysis group. So the human cell lung atlas is very much sort of, worked on and with people in Munich. And we have sort of a group on lung environment interaction. And lastly, which I think is the biggest achievement, we have an academy. We founded an academy that I never had when I was your age. I felt that I was completely on my own. There was no real people that said, listen, come with me, I'll take your hand, this is the group that you have to go to. And now we have an academy, we have more than 500 individuals in it. In these 500 plus individuals, we have 52 nations at present from all over the world. And this is what one of the achievements of that science center is as well, and we are very happy about this. So what about the talk that I try to give you in terms of content? So, one of the core projects of the DZL has been to understand early origins of asthma and allergies. And we founded a cohort which is called Alliance. And what Alliance tried to do is it tried to actually convene neonatologists and gerontologists, that's the span, for example, on the cause of asthma, with one reason. Find out what in the child determines that this disease is persistent, or whether that is actually sort of, intermittent, whether it's severe or mild, and look in the old individual with a so-called late onset disease or a disease that's always been there, what is it in its pedigree that you probably could have seen in the young child already to actually say, that is Alliance. Alliance now has 1,500 individuals in them. The youngest one is 6 weeks. The oldest one is 86 years. And basically, that is the start of this in asthma. The second thing is that we founded COSICONET. COSICONET is a cohort that looked at people with chronic obstructive lung disease. And there were different ideas around it. It was, why is it that some people get certain disease clusters? Why is it that cardiovascular disease are so inherently linked? Outside smoking, for example, what is the genetic link of it? And what is the early determinants of this? And you can hear the story already a little bit. While you do this, the ideas around this in the early origin merge. I mean, intellectually and fundamentally and biologically, they merge because there's common ground why early life events to which actually made a case. And this is when we looked at our cohort, we said, listen, what is it in fact that determines, what is the exposome, what's happening sort of very early in life? Now, when a child, there's limits to what you could do experimentally in basic science in risk for a population of 6 weeks plus. And this is why you have to know the fly. Because the fly is an animal, if you want a biological model that we use, it's ideally. So the fly is Drosophila melanogaster. The fly that was, the use of it was rewarded the Nobel Prize 25 years ago. It's actually very, very, very interesting. So the fly is answering sort of, some of these questions that we actually have. So what is the model, in fact, that you have exposome and risk factors, translating into later disease? What is these airway developmental pathways that you can postulate that would happen that you cannot study? You cannot take a biopsy of a young child. You just simply cannot do this. And basically, sort of how is it regulated, and what is it in early interventions? What do models like microRNAs, which are now becoming the major target for the novel classes of drugs? They're all RNA-based drugs, after small molecules and antibodies. That's what we have. The Nobel Prize was awarded last year for the discovery of microRNAs for a very good reason, because they will be the targets of intervention in the future. So Drosophila is absolutely fascinating because for disease pathways, 75% of the Drosophila genes are identical to the human situation, which is actually interesting. They have a very short lifespan, which makes it easy to study in models. And they are very simple in their physiology. You can manipulate their genes. They are experimental intelligence tools, and they're just a great model system. I have to tell you a story, which is actually fascinating. So when we started applying for this grant. So I was sitting around with all these people and I said, listen, that's what we're going to do. This is the people that are going to do this. Now let's talk budgets. So here was this guy, which is middle-aged, gray hair, who's a zoologist. So, everybody wanted an S3 lab and they wanted sort of, this facility on that. And they said his budget to start was 50 euros. And he said, excuse me, for what? Well, I said, I'm a zoologist. I'm working with flies and flies are cheap. I said, yeah, I can see that. So basically, this was the start of a long friendship of someone that was very sort of an ingenious person. So the fly, for example, is a super biological screening system for drugs. Because if you understand the similarities of the epithelial function and the airway physiology, you can expose these animals to all sorts of exposomes, and you can study them for drug interventions, from metformin to antibodies. It's absolutely fascinating. So we looked at these, and what we did is we looked at the airways. So you'll be surprised, Drosophila has an airway system. It has a trachea, it has a head and opening, it has a primitive way of an alveolus, it has airway segments and epithelia. And if you actually sort of manipulate these in the fruit fly and you let them, for example, smoke, you can smoke a fly. So what you can do is you can expose it, or you can have it in a little chamber where you have cigarette smoke and they fly around. Listen what, if they're exposed to cigarette smoke, fruit flies, they die earlier. They die. They don't immediately, they die 2 days earlier than the other flies that go for 21 days. So if you look at the RNA information of isolated airways, you understand there's a lot of developmental pathways from notch signaling to responsive to stress to glutathione levels that you can manipulate in a fly, in a model. So that's the ideal model to look at early interventions for lung physiology and biology. And it is dead cheap, and everybody can do it. So basically, we look at certain foci and developmental immune response and oxidative stress models in the fly, and we look also for microRNAs. And I give you just a little glimpse of it, what you can do with these very simple organisms that nobody else does. I think nobody else in the US is using Drosophila for airway pharmacology or physiology. And you know what? You should. It's really dead simple, and it's something that you can actually do. So if you look at the microRNA manipulations and delete microRNA 10, and you look at the airways of this simple alveolus that you can see here and compared to control, you see a deterioration and you see a change in the airway structure. You get airway narrowing, you get remodeling of these airways, and they get stricture, presumably leading sort of to, in fact, airflow limitation, which is, I think, extremely interesting to see. So if you look, for example, for tracheal length, alveolar cell length, alveolar branches, airway narrowing, in those with a knockout microRNA 10 in them, you can actually experimentally sort of manipulate this fly, lifespan 21 days, keep of housing 0, animal facility not needed, readily available everywhere if you just pick a piece of fruit somewhere. And that is something that sort of, gets down your research budget sort of quite significantly. Now, why now, for example, now we're talking translational science. Why now microRNA 10? Because microRNA 10, when you look at alliance in the child, is a microRNA that seems to be involved into the development of lung function, or with other words, the decline of lung function of children. So if a child would have a microRNA level in the lower decile in our cohort, the rate of decline of lung function is higher compared to those where this is intact. So microRNA from the fruit fly is probably translatable into a human system, which is decline of lung function, so difficult to study. And if you then look at children where the microRNA is low and the mother has smoked, you see that it's even going down more in terms of function. So you can actually model this in a very easy way if you translate your finding from your clinical model, rate of decline of lung function over time, with a model that you actually have. So basically, if we look at this, is in the fly, the early life smoking increases mortality. It disturbs these pathways. The microRNA seems to be important. It results in shortened lifespan. and it actually is retranslatable, if you want, to the classical chord that you have. Now, Monica graciously sort of spoke about the Balzan Prize, and the Balzan Foundation is a wonderful thing to have because it's recognizing humanities, and we were one of the very few medical groups that actually got this in a long time. It's the second highest sort of paid prize next to the Nobel Prize. So you're talking real money. And one of the things is that they ask, you have to use it for science. And we decided to dedicate part of the money, a large chunk of the money, to study the effect of smoking and nicotine products on human lung development. That's what we agreed to do. And we matched that amount with giving the same amount from the DZL funds to actually match this, to actually do this. So that's what you saw when I show you something about the smoke and the fly and what it makes to asthma. This has been continued now for looking at e-nicotine. So we're looking now for vaping products, we're looking for nicotine products, and all these things that people tell you are safe in the hands of children, they are not. Think again. They're as bad as nicotine, in some respects they're worse than nicotine, and think again, it's made by the same people that made tobacco products that lied to us 50 years ago that they think they're safe. So these are the same people that make the same products, and there's the same evil behind it, and we try to support this with data in that. So if you now, that's the fly again, if you expose a mother, a virgin female mother, to e-nicotine products before it is mating, you can study the effect of the generation following this fly generation being exposed to nicotine products. It's quite something, isn't it? And what it does is, if you look at females and males, offspring of e-nicotine exposed mothers, fly mothers, they get distorted airways. They got airway damage when they are born. So early life events before sort of a gestation is just something that drives this process. And what we're following is how much can you retranslate this to the human situation? And what it also does, and that's completely fascinating, even flies have a stem cell niche. You can study the stem cell niche to build the lung, a healthy lung in the future. So if you expose these animals, they lose their stem cell niches in it. They lose their plasticity in building organs, and that results into a changed area of airways and the development of a sick lung with thickened epithelium on the left side and cellular dysplasia in an airway of a Drosophila of a mother being exposed to nicotine in the offspring. That's the story. I think it is absolutely fascinating. I think it is extremely fascinating to see how early you actually sort of can interfere. And Balzan is at present very happy with us because that is what they were hoping people would do with research money that they get. So basically, we will continue there. We've finished a little bit of the active smoking part, but we will go on to the nicotine part. Second half of the talk. What does that all have to do with chronic obstructive lung disease? I mean, you can guess what it has to do with it, because what we are looking at, and this is where I came from many years ago, is a chronic obstructive disease that affects millions of people. It kills millions of people. It is a white male disease that have smoked cigarettes, and we start to interfere when they are 60 plus, when they got symptomatic. That's what we do. So the whole story about understanding what's happening earlier is obvious. The second part is, and me coming from drug development, is very obvious as well. How do you expect a heterogeneous disease in a 60-year-old with a bad endothelium, a metabolic disorder, smoked 60-pack years and worked in a factory XYZ, that these will actually respond to 3 drug principles for the rest of their life? I mean, how on earth can somebody so naive to believe that this is the case? And it isn't. So we need sort of intervention in there, and this is where we are. So if you study what I showed you in the fly and the asthma in chronic obstructive lung disease, you have the same phenomenon. You have, over time, you develop a lung function that is at its peaking at the year 2021, and then it declines at a different rate. And the decline of this has determinants. Something must have determined sort of, why you decline faster or slower. So you can start low. That can happen because you have early life events that makes you never attain a normal lung function, but you have something that actually drives this process. And at the end of the day, when you see someone at the age of 61 has brown fingers and smoked, you said that must be COPD. Thank you very much. This is bad medicine. It is common, but it's bad medicine. One thing, fellows of you, that you should never do, you should never diagnose now, from today on, with someone with COPD without asking him what his birth weight was and in what week he was born. Never do this again. Because you will find now the first generations in their 40s of survivors of prematurity, individuals that have 1,500 grams birth weight, that never had a good lung function, then they started smoking later, and they're a completely different disease from morbus Marlboro that you know classically. So don't forget that. Always ask someone what his birth weight was. And the men would say, oh, I don't know, I have to call my mother. Females would say, yeah, I know exactly. And there are some people that also tell you that they were sickly as a child, that they were not taking part in sports, that they were always lost. And these are the history that this is all about. And that makes us consider now these obstructive lung diseases that is separated clinically in the middle. It separates this into something on the left side where you have early origins. Some of these factors are overlapping, some of them aren't. That drives your pedigree into the disease entity aspect COPD. And on the right-hand side, you see what we do to measure it. And usually we do this with lung function. I can tell you the worst discriminator in the world to try to understand what is happening in the past is measuring lung function. It's useless because you can call it a syndrome of bad lung function. That would be correct. But what's behind it, you actually don't know. And basically also in therapies, these things will converge more and more because we understand we're looking at a common pathway late. Because between the left side and the right side, there is time. These 50, 60 years that you don't account for is modulating what you measure in lung function later on. And if you don't know where they started from, you will have a problem to understand what the disease is. The second big part that is happening now, which is interesting, is something which we call syndemics of diseases. So with other words, if you understand that you have someone with COPD, you will find that they always have comorbidities, what you call it. Comorbidities is the wrong term. Don't use it. Because the comorbidity of the lung doctor is the heart. The comorbidity of the heart doctor is the lung. So basically, it doesn't make sense whose comorbidity you are. These people have an aspect of multimorbidity. There are things that go wrong in them, with early life determinants. Bart Shelley from Boston calls these people badly constructed. These are people that have different problems that probably very likely start very early in the origin of disease. And that makes you wonder sort of, where our modern view of this is now. The modern view is that you have an exposome that is going from early to late. You have a genomic change, I will talk to this, and you have biological pathways that either make you a more emphysematous person that loses lung function and alveolar space, or you have more of a proliferative pathway that gives you epithelial metaplasia, goblet cell hyperplasia, and what have you. And this is the idea that you have, and within that, you determine sort of different diseases. So basically, in our world now in COPD, you have on the right-hand side the two phenomena. This gentleman in the upper right and the gentleman on the lower right share the same name of disease, COPD. That's the only thing they have in common. For the rest, they have a very different history of it. And in this graph, already the history plays a very important role. So the guy in the upper right hand has something which I would call a tissue minus variant of the disease. The thinnest the skin, the muscle is not there, too brittle a bone, too little of lung tissue, whereas the other one is a tissue plus. Mucus hypersecretion, tissue hyperplasia, metabolic syndrome, obesity, plaques. And the only thing they have in common, they both have an FE1 of 1 liter, but that's where it stops. You cannot practice and develop drugs that way. You have to understand what's happening on the left-hand side. So the relation between lung function change and destruction of the lung and inflammation is something which is extremely badly understood. People describe this, but the causality and the time course of this is actually very poor. And one of the things that made me come to this, what I'm doing now, is this paper from some years ago. And that looked, in fact, at lungs at a relatively early stage of COPD. And you could already see things were missing. They were missing certain segments of airways. They were just not there. They were missing sort of bifurcation. So there was a developmental aspect in it, which was not accounted for in a CT scan or a lung function or in the biology. It was developmental changes that actually drove this process, which is very important. And then came this is CAMP. Large trial performed in the US, looked for an intervention of individuals with asthma. And the most important finding of the trial is not reported in the New England. And it's in one table, at least the most important thing to me is not reported there, is the fact that if you look here, that age when the plateau of lung function in all these children was reached was at the age of 21, 22. So it was not just a theoretical concept that lung growth stops somehow embryologically, but if you measure it, the biggest lung function is at the age of 21, 22. So that, with other words, your lung function with 60 can only be as good as it was before the age of 21. That's the point. And that's the point where you have to ask people when they were born and whether they were premature. Because for your lung health and your lung development, this information and this history is extremely important. And so if you look at this paper from Fernando, who's not there anymore, what I think comprises it. You can have a normal lung function, everything is fine. You can have a severe asthma where you have somewhat impaired lung function at birth, but you can sort of, you declines more rapidly in orange. That can happen at any stage. It can happen late in life. And then you have these people that start bad, stay bad, and die bad. And these are the people, and in parts, you have to see and understand. And this is why COPD is now not a disease of morbus Marlborough and 60-year pluses, but it is a complex disease that has pathways. It has genetic backgrounds, it has early life events, it has infections ones. So that has driven this area of obstructive lung disease to a complexity which it deserves. Because to some extent, that will tell us where to interfere and intervene for either someone that develops emphysema or someone that develops an airway disease or someone that develops a relevant multimorbidity spectrum. And it will not be an ICS LABA, I promise you. That won't be the solution of all that. So what happened then was that people got more in biology again. That is translational science. So they said, why is it that some people lose lung function and COPD more than others, and we don't know that? And they came up with polygenic risk scores. Polygenic risk scores is a genetic tool that is not looking at your genetic makeup that much. It looks at single nucleotide polymorphisms, single base changes that through KI by now you can measure in the space of 1.5 million of them in an hour. You can look at, if you want, at DNA instability. It's epigenetic change, it's exposome, but it's somehow your pedigree where you came from. And when people did this in COPD, something extremely exciting happened. They looked on the left side at all the large cohorts in Europe and Asia that was performed, and they could show that you have an increased risk when you have a certain pedigree of polygenic risk scores in this 1.5 million base pairs. With other words, if you look up, upper right side, in the deciles of the measurement, so you have 1.5 hits, potentially, if you have a lot of them, you are in the 10th decile. If you have some of them, you are in the lower 1 decile. So there's an increase of chance of having the diagnosis of COPD with increases in their polygenic risk scores. So genetic instability, base pair change, drives bad outcome, bad lung function and disease. We translated this now to us because we said, if that is true, that in the COPD population at the age of 60 will have a polygenic risk score for lung function, what happens to a child with bad lung function? Because the polygenic risk score cannot account for smoking or genicity. It's the same in Europe and in Asia, but we have children that are born premature. They are born with 1,500 grams less. In Germany, we have a German neonatal cohort. These are 22,000 children. Of 2,200, we have the consent of the parents to do genetic screening of them. And what we did, we used the same polygenic risk of the adult with COPD in the child that was known to have a bad lung function to see whether this is genetics that drive this outside the risk factors that we have. And that's the data. If you look at the Z-scores for everyone on the left side or the ratio, and this is the same decile, 1 to 10, with the same polygenic risk score, the likelihood of children developing a bad lung function with the same score increases decile by decile. May I point out a p-value here that you're probably not used to in terms of whether this is chance finding. We're talking about 0.05 or a little less. This is 6.5 times 10 to the minus 9. That is the p-value of that being a chance finding. And as it happens, it is the same p-value that happened in the cohorts of COPD, by the way. It's absolutely fascinating. So that means you have now a tool that will actually make you available for risk assessment. You can say, and you can screen a child in a risk population what's going to happen, and there's something that is a very different view on this. So we believe that it's not only the early life events of early origins for the accelerated aging in the population, but it's also making the syndemic occurrence of disease very likely as well, because the same risk scores will be applicable for cardiovascular disease, to metabolic disease. So the whole scheme shifts to the left, and this is where early origins of disease is so important. And basically what we believe is going to happen that we make the diagnosis now earlier. So you can actually go for populations that are not 60 when they're symptomatic, had the first exacerbation, then there should be more in the 40s, or there should be from risk population, and there should be the child of a risk population where you look for genetic and exposome changes in them. And this is something that will now, in public health, it's the last translation score, will be important. So you have to go out to the population before they come to you, and you give them a triple therapy, which is useless probably in the given individual and costs money. And you will actually have to see sort of, when it starts. So when you look for undiagnosed disease, that's a paper that came out in the Blue Journal some months ago, and you look on the right-hand side, no, if you look at this side, on these individuals that have a St. George's, that's a health-related quality of life parameter. These are people that have, they're diagnosed with asthma or diagnosed with COPD. They have a score of around 40. If you're healthy, you have a score of 10. But if you have the disease and you're not diagnosed, you have the same symptoms. That's the left bar. So it means that in these populations, the population out is there. They just are below the threshold where they complain and where they're getting to the healthcare system. So if you proactively look for them and you can screen them for risk, you can prevent them from things from happening. And this will actually result into novel targets. One of the targets that we have is TSLP. TSLP, TSLP is something that is used now for severe asthma when people that exacerbate an oral corticosteroid and they're bad, it's a lot of money. TSLP is involved in defense against viral infections, in the development of asthma and allergy. It's not only severe asthma, it is something that occurs extremely early. It's a master switch of cellular development, of B cell and T cell development. It's a marker of how to deal with infections. It's a marker how to develop asthma and allergy. And it will be, and it needs to be, tested in the people before they have severe asthma, because to understand what the biology of this is. So also the antibody world will have to change. And this T2 inflammation that is now the target for all the intervention that you have, if you look at our cohort, translational science, and type 2 inflammation in the child, you realize it starts at the age of 2. And it is more or less constantly there at the age of 4 to 5. So the target of something which is now relegated to earlier life events in severe asthma is a master switch that is occurring very early, and it will contribute to disease outcomes outside lung function, exacerbation, what have you. And this is what I mean by opportunity of chances of this. So we're advocating with a lot of people, treatment trials in young people and much younger people. The world population studied with COPD in all clinical trials in this world is 65 years of age, predominantly male, predominantly, if not exclusively white, and they all have to have smoked cigarettes. This is a regression to a very low mean in terms of being creative and looking at population. So you need to be earlier. You need to use lung cancer screening programs of people with risk for lung cancer for lung function assessment to see whether there's something in them to actually start early with them. And this is why I think where we're going. So what I tried to convey to you in this, what you obviously understand, I live more than I work on. It's something that I do. I'm convinced that this is an extremely interesting development in chronic disease. I tried to tell you something about the DZL, which is a fascinating network. We have a website. We are collaborating with people, whoever wants it. We are open to that. We have the honor that Cap is one of our members of our advisory board, which is extremely good to have you. It's extremely good to have you because it's making this link again, and it makes it open for you to see what we're doing. And we are open. We are, like me, I mean, we're really normal people. We're talkative, but we're convinced that what we do is good science. It's translational stuff, and we like it. I told you something about, I think, what you should know about this fly. I think this is actually fascinating, what this small organism can do. And if you look outside your box, what you can develop from this. And I'm still amazed where we are. Told you something about the exposome, this sort of cigarette smoke, infections, but also prematurity and the epigenetic changes that I believe will get sort of into the clinical reality of this, of lung disease. And I just tried to give you a glimpse where I believe that the knowledge about this will open new avenues and fantasies where early interventions and development of targets and drug trials need to be coming from. And with this all, I thank you sincerely for your kind attention. Thank you.